Oh, there we go. Okay, we are going to get rolling again because I like to run a tight ship around here. And we got to make sure that we leave time for karaoke at the end. So that's going to be a walk on. Okay, all right. So our next exciting set of presentations is around the Medicare Promoting Interoperability Program for hospitals. So we've got two fabulous speakers from the Kentucky Regional Extension Center to come and talk to you. And these ladies really don't need any introduction per se, but just in case you don't know their background. So Kristina Feathers Stolitca is she works in health information technology. She's a quality improvement advisor at the Kentucky Regional Extension Center. Kristina has been at the REC longer than me. And I've been there a long time, over 15 years at the Kentucky REC and at the University of Kentucky. Woo! She has a Bachelor of Science in Health Services Administration and Healthcare Administration Informatics from Eastern Kentucky University. She has her RHIA and 20 years of working to help rural healthcare providers and hospitals navigate the changing landscape of healthcare technology. Also, we have Robin Curnel, who is also a health IT and quality improvement advisor at the Kentucky Regional Extension Center. Yeah, now my tongue is working. Thank you. It need to get warmed up a little bit. She works on the hospital promoting interoperability team. So I thought it was warmed up, but no, it's not. Quality and value team. She's also a telehealth subject matter expert. She's been with the Kentucky REC for over 7 years. She is also has her BS in nursing from Murray State, her master's in nursing management and leadership from the University of Southern Indiana, Evansville, and has more than 30 years in healthcare. I like the fact that Robin also gives us flu shots at the Kentucky REC, and she's very good at it. She is like a gentle giant in that regard. Anyway, these ladies have so much knowledge and background, and I am delighted to have them come up here and share it with you all today. Let's give them a warm round of applause.
All right, 6-second exhale, right? That's what I'm supposed to be doing. All right, thank you, Trudy. Hello, everyone. Thank you all so much for joining us today. It is great to see so many familiar faces, and it's almost like a reunion, right? I feel like we haven't done this for a while, so it's been so good to see everybody. And I've met some new folks today too, so it's been really, really great. I also want to give a shout out to our virtual attendees as well. We're so glad you're able to join us today, even though you're not able to be here with us in person. And funny enough, I even had one of my clients text me over lunch saying, "What did you guys have for lunch?" So sorry we couldn't send you lunch virtually, but we appreciate you joining us online too. So as Trudy said, my name is Kristina Stolitca. I am a health IT advisor at the Kentucky Regional Extension Center, and I am going to be presenting today's slides on the Medicare Promoting Interoperability Program. And before we dive into today's session, because full disclosure, I'm talking program requirements, there's not really a way to make it fun. So fair warning, but before we dive in, since our conference theme includes guiding healthcare improvement, I have a navigation theme Mentimeter question for everyone. And I just want to get a feel for where everyone is on the journey. So whether you're just starting out, maybe in a new position, or already cruising at full speed, I know we all have kind of had our own unique path when it comes to the Promoting Interoperability program. So if you can, go ahead and scan and choose the option that best describes where you feel your organization is right now. So are you still packing your bags, or have you hit a few detours? Okay, some detours. Looks like we've got a few adventures in the woods. All right, well, thanks for that. And hopefully I can help guide you through some of the program complexities today. Okay. All right, we're going to go ahead to our agenda today. So first, I'm going to cover the Medicare Promoting Interoperability requirements for hospitals. Oh, I think we jumped ahead twice. There we go. So for 2025, what's expected, what's changed, how to stay on track. Next, I will highlight the IPPS, the most recently released IPPS rule, the Inpatient Prospective Payment System final rule, and specifically the updates that affect PI participation. And then we'll wrap up today with some action items and reminders to help you move forward confidently. So let's go ahead and jump right in. I'm not going to spend a lot of time looking back, but just as a quick reminder of how we got here, the American Recovery and Reinvestment Act of 2009 required CMS to incentivize hospitals to adopt, implement, and upgrade certified EHR technology. In response, the EHR incentive program, formerly known as Meaningful Use, was introduced in 2011 under the HITECH Act. And just a quick show of hands, who in here still calls it meaningful use? Oh, look around. Okay, all the EKU students, take a look around at those hands in the air. Those are the OGs. And so CMS rolled the program out in progressively more challenging stages and initially offered incentive payments, which continued through 2016 for most hospitals. Now, as we moved through stages 1, 2, we had a modified stage 2 for a little while, and now stage 3, CMS maintained its core focus on advancing certified EHR technology. More recently, CMS overhauled the program to increase flexibility, reduce provider burden, and emphasize the electronic exchange of health information between providers and patients. The focus really shifted toward improving patient access to health data, driving interoperability. And the Medicare Promoting Interoperability program, as we know it today, includes a set of objectives, measures, and other requirements that together determine whether an eligible hospital or critical access hospital has met the standard of a meaningful user. So while the incentive payments ended long ago for hospitals, they must actively participate in the program each year to avoid a downward Medicare financial adjustment. And important to note, unlike many other CMS programs, the Medicare PI program has no defined end date. So this slide lays out the framework of the Medicare PI program for 2025. First, the reporting period is any continuous 180 days. And as in prior years, hospitals may choose a longer reporting period up to and including the full calendar year. In addition to reporting on objectives and measures, hospitals are required to submit 4 calendar quarters of electronic clinical quality measure data. They must use certified EHR technology that meets the current ONC certification criteria. And you might remember that this was previously called the 2015 edition. So just know that that naming convention of certain editions is no longer in use. And then the security risk analysis measure remains a core requirement of the program, reinforcing the importance of protecting patient health information. And Amy did a really fantastic job this morning, kicking us off and teaching us all about HIPAA. Hospitals are also required to attest to the Safer Guides measure. That stands for the Safety Assurance Factors for EHR Resilience. In 2025, CMS is continuing the performance-based scoring methodology. So to successfully attest, hospitals must earn at least 70 points. And that's up from 60 last year. And just a heads up, it bumps up to 80 points next year. And then finally, the attestation deadline has already been set, and that is March 2nd of 2026. So for 2025, hospitals are required to report on 4 main objectives in the Medicare Promoting Interoperability program. This slide shows the point distribution broken down by measure. So let's walk through them. Electronic prescribing, that includes generating and transmitting electronic permissible prescriptions, along with the query of PDMP measure. Next, the health information exchange objective encourages and leverages interoperability and promotes health IT-based care coordination. And there are 3 reporting options for this one, but hospitals only need to choose one. So first is the support electronic referral loops by sending health information, and that also includes the supporting electronic referral loops by receiving and reconciling health information, or then one of the alternate measures, the engagement in HIE through bidirectional exchange or the enabling exchange under TEFCA measure. Next is providing patients access to their health information. And then lastly, the public health and clinical data exchange objective. And these are the measures that a hospital attests yes to being in active engagement with a public health agency or clinical data registry to submit electronic public health data using CERT. And there are 5 bonus points for hospitals who choose to report the public health or clinical data registry. Okay, before we move on from public health, I do want to take a moment to review active engagement because this is an important piece of it. So hospitals are required to indicate their level of active engagement for each public health measure during attestation. And in recent years, CMS consolidated and renamed these engagement options. So option 1, pre-production and validation. This means that the hospital has registered to submit data and that registration happened within 60 days of the start of the reporting period. And then they begin testing and validation of electronic data submission. For option 2, validated data production, this means that the hospital has completed testing and is now actively submitting production data to a public health agency. And starting last year, CMS began requiring hospitals to limit the duration of their time spent at option 1. This is really important. So for example, if your hospital reported option 1 for, say, electronic case reporting in 2024, then you must move to option 2 this year for that same measure, or you would fail the public health objective. So CMS's goal here is really to move all providers nationwide into active production data exchange so that health threats can be monitored, because it doesn't really help, if nothing's going back and forth during a real public health emergency. So they've just been clear here, facilities can no longer linger in registration for years or, in testing. So I know this affects a lot of hospitals. If you're one of those that maybe has been stuck in testing for a while, or if maybe you've been hanging on with that signed KHI addendum, you got a not so gentle nudge here by CMS to move forward into production. And we do know this impacts a lot of hospitals. One important caveat to mention, the separation of the AUR measure this year in 2025, these are now considered new measures. So for AU and AR this year, you can use option 1 again, but then for next year, you would have to move into option 2, so in 2026. All right, moving on to scoring now. It is performance-based. It happens at the individual measure level. So the scores of each of those individual measures are added together to calculate a total promoting interoperability score up to 105 possible points. Now, as I mentioned, a total score of 70 points or more is needed to satisfy the CMS requirement. Hospitals scoring below that 70-point threshold would not be considered meaningful users and will be subject to Medicare payment reductions. It's also important to remember that you must report on all the required measures to earn any score at all. So if you submit a 0 for a numerator or a denominator, or you say no to a yes or no required measure without claiming a valid exclusion, then unfortunately your hospital would fail the entire program and receive a total score of 0, resulting in that payment penalty. Okay, let's talk about CQMs now. So to successfully participate in the Medicare Promoting Interoperability program, hospitals are also required to report on electronic clinical quality measures. And these do require the use of certified EHR technology. These measures rely on EHR data and are tools used to measure and track the quality of care provided in hospitals. In 2025, hospitals must report on 6 ECQMs, so 3 required and then 3 additional of your choice from the approved list. And a few important things to mention, the reporting period is the entire calendar year, so that's going to be the 4 individual quarters. And hospitals must report the same ECQMs across all 4 quarters, so no switching mid-year. And while there are no performance thresholds to meet, for these measures, meaning you're not scored based on the outcomes, the data must be reported exactly as generated by your hospital CERT and then submitted through the hospital quality reporting system. And you can use any combination of QRDA Category 1 files, zero denominator declarations, or case threshold exemptions. Okay, I always say it's interesting how CMS uses the word eligible. We hear it all the time, right? When describing participation in these programs. So an eligible hospital, an eligible participant, eligible clinician. And I always say, I guess that's just their nice way of saying mandatory, because let's be honest, you don't really have a choice unless you're okay with a payment penalty. So let's talk about those payment adjustments. Where are all the hospital CFOs at? They're perking up now. It's not just IT. The legally mandated penalties under HITECH are still in full effect. So that's why success in the Medicare PI program matters so much. It's not just for quality, but your bottom line too. All hospitals must successfully attest to the program every year to avoid an annual downward payment adjustment. And here's how that works. So for eligible hospitals, their payment adjustment is applied to the Inpatient Prospective Payment System. So it's applied as a reduction to their inpatient payment rate for that fiscal year. It specifically reduces the update to the standardized amount by 75%. And then for critical access hospitals, it's a little bit different. The penalty is applied as a reduction to their Medicare reimbursement for inpatient services. So going from 101% of reasonable costs down to 100%. All right, moving right along, let's take a look ahead. And I'm just going to highlight some of what's included in the latest IPPS rule. As many of you may know, these IPPS rules are released annually, and they update policies across a number of CMS programs, including the Hospital Readmissions Reductions Program, Value-Based Purchasing, and IQR, among others. But it also updates the Medicare PI program, and I'm just going to briefly highlight that section for you today, just to kind of give you a preview of what's coming and a look ahead. So first, CMS will continue the 180-day reporting period in 2026 and beyond, so no surprises there. You can continue to plan around that timeline going forward. Next, changes are coming for the security risk analysis measure, and this is a big one. Currently, CMS requires hospitals to attest yes or no to having conducted an SRA. So very basically, did you do it? Starting next year, CMS is going to require that hospitals also complete a risk management plan, and that's referenced in the HIPAA security rule. All right, the safer guides are up next. These are evidence-based practices designed to help hospitals improve the safety and usability of EHRs. And they were originally released in 2014 and then updated in 2016. CMS adopted this Safer Guides measure as a requirement in 2022 and didn't make it mandatory until 2024. So for this year, hospitals can still use that 2016 version, but starting next year, they want hospitals using this updated 2025 version, which was just recently released by ONC. And then back up because there's one more on there. CMS did add a third optional bonus measure under the public health objective. And just keep in mind, if you participate in 1, 2, or next year, this new third option, you can still only earn a maximum of 5 bonus points. All right, lastly today, let's review some action items and reminders for 2025. So this slide just gives a quick summary of what I've covered today for the Promoting Interoperability program. The reporting year runs January 1st through December 31st. That CMS HQR attestation portal opens January 1st, and the data submission deadline has already been set for March 2nd, 2026. I will also point out the hardship exceptions. So CMS recognizes that unforeseen circumstances can occur, and that might prevent a hospital from meeting these requirements. So in those cases, hospitals can apply for a hardship exception to avoid that downward Medicare financial adjustment. I will note that simply not having CERT does not qualify for an exemption. These are reviewed on a case-by-case basis by CMS. If you're approved, it's only good for 1 year, and CMS only approves 5 hardships per CCN lifetime. All right, I've included this slide. It's a participation checklist that's a helpful resource. And then we're almost done. And I should have added another poll here to just do a quick check and see how everyone's feeling about this Medicare PI journey now. Hopefully, you'd be ready to hit the road, maybe, you know where to start now, or still in the woods, but with a better map, or maybe on track and arrived, and that's what we're aiming for. So wherever you are on the path, just remember you are not navigating this program alone. The Kentucky Regional Extension Center is here to help guide the way. And before I wrap up, I just want to take a moment to remind you how we can support your hospital throughout the year, not just when it comes time to attest. So first and foremost, keep running those PI reports. And I'm looking at a table of client hospitals right now. They send them to us as often as they want to, and we take them, and we like to see them. We have some that send them weekly, monthly, others at least quarterly. We do like to lay eyes on them to make sure we don't end up with any surprises at the end of the year. But we'll take that data and plug it into our gap analysis tool. It gives a visual dashboard, an estimated total score, and then really helps us track trends in the data over time. It's a great tool to help identify potential gaps early and make course corrections if needed. And we're also happy to meet regularly, whatever works best for your team. We do a lot of Zoom and team calls. Some hospitals schedule with us as needed, and other ones we have recurring monthly meetings already set up. So whatever works best for you, we can help clarify program requirements, talk through strategy, and answer any questions that you might have during the year. So just keep that in mind. The Medicare PI program might be ongoing and complex, but you don't have to manage it alone. We are here to help every step of the way. And not just with this program, but a lot of other programs as well. So with that, I thank you all for your time and attention. I know it's very program specific, so thanks for sitting through. If it doesn't apply to you, take it home and share it with others at the clinic or hospital near you. So if you have any questions about anything I've presented, I am going to be here all day, so come find me and let's chat. And now I'm going to turn it over to my partner in crime, Robin. She is going to share with us about a recent project that supported critical access hospitals reporting to the Medicare Beneficiary Quality Improvement Project. MBQIP, right?
Binder. I think I could do this in my sleep, but just in case. Thank you. So I was real tickled that Kristina did that part because I've done it the last 3 years and I just don't do it justice. So I was real tickled. So for starters, we don't know generally what the other presentations for the day looks like when we get started until the day of. So I was real tickled this morning to hear Katie and Jessica talk about high reliability organizations, because I feel like what I'm going to share with you this afternoon is a perfect example of some folks getting started towards that journey, and they probably didn't even realize that's what they were doing. The other part is that I haven't really done a lot of work on the hospital ECQM side or really into quality improvement. And so we started dipping our toes into that with our partner, the Kentucky Office of Rural Health. And it was more like going in waist deep after we got into it. There's a lot to it. So we worked with some critical access hospitals this year, and they asked us to meet with them on some specific things. We were to help recruit at least 4 organizations to work on submitting to the Medicare Beneficiary Quality Improvement Project, or MBQIP, and then at least 2 more hospitals to work specifically around social determinants of health. And it's SDOH to me. It might be health-related social needs. I mean, it's getting all kinds of new words, but that's what our goal was. So that was our scope. Our plan was to provide technical assistance to these folks, work with them on quality improvement methodologies, talk to them about what's currently going on in their practice around SDOH, and then we had a timeline. We started in February, we wrapped up in August. And so I think it was a pretty quick timeline, but what I want to share with you today is a lot of great progress. We were proud to honor one of our groups this morning with the Medical Center of Albany, but I'm telling you, anybody that was part of this group, any of those 6 could have qualified for that because the work they did was outstanding. We have several of those folks with us today, and we have several on the call, on the Zoom with us. So that was our project. This is our results, and I'm going to talk to you about how we got there. One of the goals was to successfully get hospitals who had never participated in MBQIP before, get those to submit for 2014. So we started in February. The deadline for reporting is in May. So just think about that. And we still had to recruit. We were successful. All of our hospitals reported at least one measure in that program. Even better, we had others that submitted all of the measures. So I felt like we had reached a really good goal with them. We also worked with them on establishing their goals for 2025. You know, it's not a matter of just reporting. I want to back up one thing. This program, MBQIP, is still voluntary for critical access hospitals. We know at some point it's going to become required. So these folks are getting ahead of the game with what's required to submit to these programs. So we worked with them for what goals they wanted to meet for 2025. We wanted to move from just reporting a measure to making some improvements in it and recognizing that those measures are people so that we have improved outcomes. We also worked on our folks who wanted to work on their social determinants of health referrals, actually helping them get connected to those community-based organizations. And I've talked about SDOH in past presentations, and we all want to screen everybody. We know everybody has needs, but what do we do with it after that? Because there's just not enough community-based organizations to go around, or we just don't know who to communicate with or who to contact. So that was another one of our goals internally, was to help get these folks figuring out how to find out who in their community or who in the community in which the patient lives has these services. And then also expansion of their quality improvement teams. We wanted to help the quality staff get quality work outside of the quality department, because let's be real, that's not where change happens. Nothing against our quality staff, but they know it too, and they get really frustrated. So what did we do over these last 6 months? We started with monthly meetings. We asked them to devote specific time to this work so that we all had a dedicated moment each month to work on it. They were no less than monthly. I will tell you, some organizations we met with twice. Others would spontaneously call and say, hey, we need to talk about this. We would do it. I had a great team. I don't want to leave them out. Vance was part of it, and Alicia as well this morning. And where's Tabitha sitting right there too. So I had a great team. This was not all, it was just, you couldn't ask for a better group. We also were tasked with 3 learning sessions to develop 3 learning collaboratives, again, in this 6 months. And I think we knocked it out of the park personally, but anyway, we set them up with Connect resources. We did one session just on quality improvement methodology. And then the last one was actually a showcase of the work that our participants had done during that time frame. Originally, we were just going to offer these collaboratives with just our SDOH folks, but after the first one, we decided, no, we need to bring in everybody that's participating so they could all share their best practices. And then we talked to them about the PDSA model for quality improvement. I mean, Plan, Do, Study, Act. We believe in keeping it simple. I believe in keeping it simple. The other thing that we told them around PDSA is that it doesn't have to be something super big and complex. It can be something very small. And that's where we sometimes get hung up on quality improvement, is we want it to be some big elaborate project. And when really the change is in the details, it's in the little things. So we worked with those on that and implementing that kind of methodology if they didn't already have something. And then measure selection. We all know you got measures coming in from HRIP, and you got measures coming in from Medicare PI and Medicaid. It's just all over the place. And so we worked with them to find measures that maybe cover 2 or 3 programs that we could really make some good progress with. And if they weren't participating in those programs, maybe what's important to you all? What did you have in your strategic plan that you wanted to work on? And then we talked about goal setting. we got baseline data for each of those measures that they wanted to work on. And then we talked about realistic goal setting. So, okay, we have 6 months to make an improvement. Well, your baseline's at 50%. Are we realistically going to get to 95 in 6 months? No, we're not. What do you want to see that's realistic? We talked about SMART goals. We get to 5% change, we'll take it. So we talked about, baseline setting and realistic goals. And then test of change, or these are your interventions. What does that look like? What kind of best practice? We worked with all of these hospitals on what works for them because we know that we don't like cookie cutter medicine. So we worked on what's important for them. We encourage them to bring in teams, to bring in people. It works to bring in people. And I know that's a battle that you all fight. I was a CNO in a small hospital. Listen, I know what battle you're fighting. It needs to stay in a room. They brought it in and it worked and they were very successful. We also helped them with data collection. So we get all this info. What do we do with it? What is it? What's actually meaningful? The worst thing I hated to hear was, well, that's how we always did it. We're collecting data on measures that we don't know what to do with them or why we even have them anymore. So we worked with them on data collection to be what was meaningful. One of the things that we talked about was when you were bringing in folks, they were like, we don't know who to get engaged. Do you have champions? Do you have some frontline folks? I would tell some of them to bring in their complainers. And that seems so bizarre, but your complainers are engaged and they probably have a solution. They've just complained about it. Nobody's listened to them. So I really feel like that all of this work that these organizations have put into is just really a good example of how you move into becoming that high reliable organization that they talked about this morning. So I know I'm on a timeline and I did put my phone on Do Not Disturb. So successes, I know this is small print and it's hard to read, but these don't seem like a whole lot, but it made a big change for a lot of these folks. Workflow mapping for patient portal access. And you're like, well, how does that matter with patient engagement? Well, they put that into place because they were trying to reduce the number of phone calls coming into their clinic, asking about labs and things like that. So they started education on patient portal access. They first started with just a one-pager sheet that registration could give out. They started this in their small cardiology clinic because they could work with one provider. Well, that steamrolled into, well, okay, we got a one-pager. How about we make a little mini video and put it on our website? And then that rolled into something else. They just kept going even beyond our help. So it's just those little things. The expansion of quality teams. Another hospital brought us in and said, listen, we want you to meet with our department leaders and give them this education. And at first I was a little bit like, I don't know if we want to do that or not, but we did it. And it was very successful. And we heard lots of good compliments about that. They even brought some of those team members in when they did their showcase and really bragged about it. So these are all examples of what they put into place over these 6 months to make changes to the measures that were applicable to them. The other thing that we used as a measure of how successful this project was overall was how many of these critical accesses reported in 2023. Of the 6 that worked with us, how many reported anything to MBQIP, and then how many not only did they report 24, but had plans for 25. So we started with 6. These are the core measures for MBQIP. MBQIP actually has, I think, about 18 measures altogether, but they have a core list. So we have core and supplemental, and this is the number that we started with who had submitted various measures and then others for 2024. Some of these measures, they were doing the work for another program, but it was just a matter of saying, hey, NHSN, we need you to submit this for us. And they just didn't know where to go. One of the things that we heard early on was, I have all these logins, but I don't know where to use them. So what we've learned from this project was some challenges and some opportunities. One of their challenges was turnover in quality staff. I mean, it's a small hospital. We know how that goes. Folks get put in positions that they've not been in before, or the position has been vacant, and so they're filling in a spot. Several of the folks that we participated with were new in their roles. One organization really didn't even have a defined quality staff member. They had about 3 people they were pulling in together and nobody to really be the funnel to what all needed to be reported and when. Not only that, they also didn't have time to really focus and devote on improvement. They were getting that reporting done, but just barely in, but they really didn't have time to work on reporting or improvement. So opportunities, first of all, we would like to have seen that this project be expanded for a full year. We would like to see the fruits of their effort for 2025 to see how that goes. And we'll follow up. I think I'll probably be nosy and just ask. A boot camp for new quality measures. Our quality management staff, just so they have somebody that is a resource on what they can do. Expansion of this collaborative or network of these facilities, bring in more groups, and you all can be the example. Med Center's here, Russell County was here, they were part of that project. Bring in more folks and use more of a collaborative approach meeting that. And then finally, measure alignment. I mean, that's a pain no matter what program we're participating in. I mean, it just really is. This people want this and this ones want that, and everybody's got money tied to it. All right, so I am wrapping up that session. All right, we have what, 5 minutes? What have we got, Megan? Somebody back there in the back. Okay, all right. So we have a few minutes before we present our award to take a couple questions. Or if you want to use the Menti, if you have any questions for me or Kristina, either one, we'll take those. And then I'll let y'all put your questions in and maybe I'll read about our award. Does that look okay? So I covered that very quickly and I'm very sorry I went so fast. So Hospital Promoting Interoperability Excellence Award we are honored to present this year's Promoting Interoperability Program Excellent Award to TJ Regional Health in recognition of their outstanding commitment to advancing healthcare technology and improving patient outcomes through the Medicare Promoting Interoperability Program. Over the past year, Jennifer Robinson and Sherry Ogg from their TJ Sampson Community Hospital and TJ Health Columbia have demonstrated exceptional leadership and dedication in meeting and exceeding the program requirements. They have a proactive approach to health IT adoption, data-driven care coordination, and patient engagement has not only fulfilled the objectives of the program, but also set a benchmark for excellence in the field. And this award celebrates their success in leveraging certified EHR technology to enhance clinical processes, improve health information exchange, and drive better outcomes for their patients. Their achievement reflects a deep organizational commitment to innovation, collaboration, and continuous quality improvement. So please join us in congratulating TJ Regional Health on their outstanding accomplishments. Let's get over so you can get the picture.
We need to go over here.
What's it going?
Yeah, I'll put it here so it'll be in the middle.
Real quick, we're very honored to have this award, but we would not have this if it wasn't for these 2 ladies up here. We really appreciate both of you, all of the knowledge that you've shared with us, all of the support, as well as Jessica and Tabitha in the back. They're the ones who introduced us to these 2 wonderful ladies, and our success is due to them. So thank you.
Thank you. I'm gonna see if we have any questions. All right. Do you have any questions for us? Are we good, Jared? Anybody else? All right, Trudy.